Okay, we move on to the next talk by Dr. Parthopratim Majumder, and he would be telling us about managing cataract in patients of uveitis. Dr. Parthopratim is a senior consultant of uveitis, an anterior segment at Shankar Nethralaya, Chennai.
It took a little more time.
Good afternoon, all. First of all, I'd like to convey thanks to Manisha ma'am for including me in this IC. So I'll be talking on managing the cataract in uveitis. Now, if you see here, these 5 cataract cases were operated by a skillful surgeon, and you can see the outcome was not that great. So two most important things you have to remember for the successful outcome in cataract surgery in uveitis are the pre-op and the post-op immunosuppressions, because this defines that how successful your cataract surgery will be. So I'll be sharing some tips with that. Now, one myth we believe that if the eye is quiet for 3 months, then we can go ahead for the surgery. Now let's see 2 scenarios. Will you operate these 2 cases? One 28-year-old male, history of recurrent attack of uveitis in the past, HLA-B27 positive, and last attack of uveitis was 4 months back and not on systemic medication. Similarly, a 61-year-old female, history of recurrent attacks of uveitis due to VKH, and the last attack was 6 months back, not on systemic immunosuppression. So many a time, what mistake we do, we forget that the patient is not on systemic medications, and sometimes the last attack is more than 3 months back, so we feel that we can go ahead and do the cataract surgery. I think that is not wrong in India, because sometimes the patients with uveitis present to us with the complication, like complicated cataract. So these are the cases you need to start the patient on immunosuppressive and then take them for surgery. Now, 3 important points we need to understand. The one is identify the etiology of uveitis. Like if it is due to Fuchs uveitis, then there is no need of steroid cover. You can directly go for the cataract surgery. If the patient is on toxoplasma, retinochoroiditis, white dot syndrome, they are less likely to develop recurrence. Whereas on the other side, the juvenile idiopathic arthritis, HLA-B27, VKH, idiopathic anterior uveitis, these are high likely to develop recurrences of inflammation after cataract surgery. Now, the second point you have to understand that you have to make sure that whether the patient is on effective immunosuppression and for sufficient amount of time. Now, the number 3 point is very important. These are the 2 important clinical signs you have to look for when you are planning to do a cataract surgery. The number 1 is that extensive posterior synechia. If there is extensive posterior synechia, it is very much likely that the patient will have high risk of post-operative inflammation. And secondly, the second important clinical sign is macular edema, the macular edema usually denotes that severity of the uveitis and greater risk of relapse after the surgery. Now, I'll just share a few tips here. Like when we see this kind of occlusio pupillae, where a fibritic membrane covers the pupil, so one should actually utilize those PI to inject the viscoelastic. So that will elevate the entire iris tissue forward, and then we can actually insert a 26 gauge needle and create an opening with that. The next important is when you see this kind of peripheral anterior synechia, you need to understand that you have to do minimal separation. No need to go inside and extensively separate the peripheral anterior synechia, because sometimes these are notorious and they can cause damage to the Descemet's membrane also. Now, I won't be discussing in details with the management of small pupil. I'm sure all of you know how to do this. One important thing I want to tell you that if there is a large pupillary membrane, it should be incised with the microvitrectomy scissor and should be stripped from the pupillary margin before you start proceeding with the phacoemulsification. Now, just few tips about the bimanual pupil stretching with the Coughlin hook. So you have to remember, if it is a smaller, very small dilatation, then only Coughlin hooks works best. So in moderate dilatation cases, better not to use the Coughlin hooks. And second thing, if there is a very shallow AC, then it's better not to use the Coughlin hooks, because sometimes it can cause a damage to the corneal endothelium. Now, Now, Grishaber hoops, all of we use. One thing you have to understand, because when you start using Grishaber, especially the newcomers or the new surgeons, because the Grishaber hoops sometimes causes the tenting of the iris tissue. So once if surgeon is not careful while entering the phaco probe, they may cause iridodialysis and cause damage to the iris tissue. Now, capsular rhexis we all know, but two things we need to understand in uveitic cataract. If they are small, if the rhexis is small, then it can develop postoperative synechiae with the anterior lens capsule or the rhexis margin, and sometimes it can lead to capsular phimosis also. Now, if the rhexis size is very large and eccentric, then this can happen. You can see here in this picture, a part of the intraocular lens is popping up, and this is rubbing the iris when it is not dilated, and that's how you can see this in schematic graphic, that it can cause inflammation of the iris tissue because it's rubbing the posterior surface of the iris. So one should avoid making a very large or eccentric rhexis in cases with uveitic cataract. Similarly, here is another picture. Though the lens is inside the bag, you can see that because of the very large rhexis, a part of the IOL is popped up and it is rubbing the iris, thereby causing a significant inflammation. Now, sometimes, as we know that we need to remove the cortical material properly because these are highly antigenic, but sometimes it can be very difficult because when you are using Grishaber hook specially, because small particle, maybe small lens matter can be there inside the pupillary area, and the patients with high arcus analis, you can miss here, as you can see here in this blue arrow. There is a swollen actually cortical retained lens fragment which is hiding there and causing significant inflammation. So similarly, you need to understand, and because these materials are often lodged in the posterior chamber, and when after surgery they can cause significant inflammation. There is no alternative to hydrophobic acrylic lens, because you see here one silicon plate IOL was used, and you can see this is an electroscopic photograph which is showing that the inflammatory cell is invading the lens surface and going inside it. So always be careful about choosing your lens. Now, coming to my last segment, that cataract surgery in setting of scleritis, we have reported 38 cases of such cataract. So what we have realized, that if your immunosuppression is proper, sometimes you can go with the scleral incision. Now, why scleral incision? Because sometimes you will have a very thin cornea, peripheral, because of the healed peripheral ulcerative keratitis, and extremely thin cornea, so you may find it difficult to go for the corneal incision. So these are the cases you can actually go for scleral incision even in scleritis patients. So sometimes there will be a lot of, you understand that necrotizing scleritis is most common to develop the cataract, but if you are doing proper job, proper immunosuppressions, you can go ahead and do a good cataract surgery also. For example, this patient we could manage without a patch graft, and the patient is doing well till now. So sometimes because the scleral rigidity is very less, so you need to apply a suture so that you can secure the wound properly in this scleritis cases. Now, two slides about the pediatric uveitis. This is a boy, 6-year-old boy. You can see here we have treated the boy with juvenile idiopathic arthritis patient with adalimumab and methotrexate for last 1 year. And after 1 year, we have the boy underwent cataract surgery in both eyes. One eye, the cataract was the intraocular lens was well tolerated, whereas in other eye, the patient did not tolerate, and ultimately we need to explant the intraocular lens. So this is very important lesson we learned, that the differential IOL tolerance in identical disease with similar immunosuppression. 1 year of adalimumab and methotrexate, the same disease, but one eye tolerated the intraocular lens, whereas in other eye we need to explant the intraocular lens. So few things you have to understand, that no rule that fills all the eye. If it is a shallow anterior chamber, there is a severe inflammation. If the patient is having a hypotony and age is less than 4 years, then better to avoid intraocular lens in children. Just last slide, that one thing you have to understand when in pediatric cataract you do a posterior capsulorhexis and try to do anterior vitrectomy, you have to understand that these are uveitic eye prone to develop significant traction. For example, a patient of intermediate uveitis, you are doing a posterior capsulorhexis and doing anterior vitrectomy, you can actually create significant traction and thereby leading to retinal detachment. So it's always better to take this patient for pars plana vitrectomy if you feel that there is a vitreous opacity which need to be removed. That's it. So I'll just conclude my presentation here, that as is your pre and post-op immunosuppression, so is your outcome of cataract surgery. Extensive posterior synechiae and macular edema, two important clinical signs you need to evaluate before you take the patient for your surgery. Scleral incision can be used in certain conditions in peripheral ulcerative keratitis and necrotizing scleritis, provided your immunosuppression is proper and appropriate. Large and eccentric rhexis can be a rare cause of posterior inflammation, so don't try to avoid the very large rhexis. And no rule that fits eye in pediatric cataracts, so you have to decide judiciously on putting the IOL in these patients. Thank you.
Thank you, Partho. I think you've given some very important tips during your presentation for planning a cataract surgery in a patient of uveitis, which are always a challenge. I wanted to ask you one thing, that very often we see these patients after the cataract surgery, when they develop a posterior capsular opacification, it's very thick. And even after you have done a YAG cap, it tends to regrow. So what would be your suggestion how to deal with these patients?
I think these are the patients we have started doing. Before we do a YAG cap, we hike up the oral steroid in these patients. We plan that we'll be doing YAG cap, but before that 40 mg oral steroid we hike up. And immediately after the doing the YAG cap, if the patient is not steroid responder, I give a periocular steroid. Because just
after the YAG cap?
After the YAG cap. But still, in spite of that, sometimes they developed, and it is very difficult to, you have to sometimes manage them surgically.
Also, it's a very nice presentation with a lot of schematic diagrams. You really hit some of the salient points. My own impression over the years, like I was doing practice of uveitis 40 years, those eyes in the GIA or children with the pediatric uveitis has been implanted. Many of them has become a disaster in that one, is my experience. What is the lesson which you wanted to give in such cases?
So we have to be highly selective in putting the IOL.
Yeah, I agree.
The aim of managing juvenile idiopathic arthritis will be to delay the cataract surgery as much as possible. Like 14 years or 15 years. So you can delay the progression of cataract by minimizing the topical steroid and starting the methotrexate early. That is the best option.
I was thinking that whether we can give biologics in this patient and then give
Even
the
after
cataract.
biologics, sir, I showed the patient one eye, we need to explant the IOL.
So I had a question. Are there any indications which will be an absolute pointer that these are the eyes where you should not put an IOL?
Yeah, that's what I quoted this from an article. Actually, I forgot to put the reference. So and I realized that the patient where we need to explant the IOL, that has a shallow AC. So shallow AC in GIA, I think contraindication for putting
So
IOL.
just I thought, would it make sense for us to do a UBM in these eyes and see if there are any ciliary body membrane?
Yeah,
Those are the eyes
absolutely.
where we should not be possibly thinking of putting an IOL. Just a question.
I think the message should be that for JIA patients, the best is that we don't put in an IOL.
Lens and vitrectomy.
Yes.
Lens and vitrectomy
Yes,
is safe.
absolutely.
I didn't find any patients losing the vision.
Correct.
Is doing a cataract surgery is much more dangerous than not to do a surgery.
And-
Cataract surgeon need to control his ego.
Yeah.
And I think PGI Chandigarh is now coming up with a long-term follow-up of the JIA patients who underwent cataract with IOL implantation. And they apparently are also advocating that it is best that these children are not put in with an IOL, because I also, in my experience, I have explanted majority of these patients with the IOL, despite they being on an immunosuppression, very well-controlled inflammation prior to the cataract surgery. So I think we really have to hold back the IOL implantation, and probably in the later stage of their lives, if they are doing well and they are, adequately immunosuppressed, I think that's going to be the best time to put in the IOLs. So that is something I think we would all agree.
Another thing is that the patients who underwent cataract surgery with IOL implantation, we don't have that long-term study, that after surgery what happened
Exactly.
to them. So very short, one year maximum the follow-up, and they say that they are doing well.
So I think that PGI Chandigarh study will add knowledge to us, because they are also saying that they had to, majority of them had to explant the